Welcome to the deep dive. Today, we're tackling a really common condition, something you're almost certainly going to encounter, Dupuytren'scontracture.
Exactly. Think of this as, well, your focused revision session. We want to cover everything crucial about this progressive hand issue.
Right.
Our goal, really, is to make the key facts stick, make them memorable for you.
Okay, so let's paint the picture. Someone starts noticing maybe their hand isn't quite flat anymore, a finger starting to curl in. What's actually happening there with Dupuytren's?
Yeah, basically the tissue layer just under the skin, in the palm, and extending to the fingers, it starts to thicken up and tighten abnormally.
Thicken and tighten.
Right, and this creates these firm little lumps, we call those nodules, and then these tough band-like structures or cords.
Ah, okay.
And the big issue is that these cords, over time, they can pull the fingers inwards, leading to what we call flexion contractures. It's more than just stiffness. It's a real structural change happening.
So what actually causes this abnormal thickening? Is there like one single thing that sets it off?
You know, that's one of the interesting and maybe frustrating things. We don't actually have one definitive cause pinpointed.
Ah.
It really seems to be a mix, a combination of genetic predisposition and various environmental factors.
Okay.
We definitely know certain things significantly up the odds. Your genes, getting older, and even being male plays a part.
Right, a bit of a puzzle then, but with some strong clues. Let's dig into those clues, the risk factors. Who needs to be particularly aware?
Well, age is a big one. It becomes much more common if people get older, usually kicking in for those over 50.
Over 50, okay.
And there's a really, really striking gender difference. Men are something like 6 times more likely to develop it compared to women.
6 times. Wow, that's a huge difference. What else is significant?
A strong family history is definitely a key indicator. It really points towards that genetic component we mentioned.
Mm-hmm.
Also, it's much, much more common in people with Northern European ancestry.
Right.
And here's a really key point for revision, something memorable. Smoking. Smoking actually triples the risk.
Triples it. That's huge for a lifestyle factor affecting, well, what seems like a structural hand problem.
Absolutely. It really drives home that connection,
Yeah.
What else? Alcohol consumption is also linked, especially it seems, with alcohol dependence.
Okay.
Diabetes, another big one. It's noted more often in type 1 diabetes. And get this, about 1 in 5 people with diabetes end up developing Dupuytren's.
1 in 5. That's a really strong link to remember.
It really is. Other things that might play a role include repeated hand vibration, maybe from certain jobs.
Right, occupational hazards.
Yeah. Also, raised lipid levels in the blood. And there seems to be a possible link with epilepsy, and specifically the anticonvulsant drug phenytoin.
Interesting.
And even things like manual labor, even without that heavy vibration. And maybe previous trauma to the hand have been suggested as possible contributors.
So quite a wide net of potential influences. Okay, let's get into the biology. What's actually happening inside the hand tissue that creates these lumps and cords?
Okay, so picture the palm of your hand. There's this layer of fibrous tissue called the palmar fascia. It's sort of like a supportive mesh.
Right.
In Dupuytren's, specific cells in this fascia, they're called myofibroblasts. You can think of them almost like overenthusiastic repair cells. These start multiplying way too much.
Okay, overdrive repair mode.
Exactly. And these superactive myofibroblasts then start laying down excessive amounts of collagen. Collagen's the main structural protein, the sort of building block of this tissue.
Got it.
So this overproduction of collagen causes fibrosis, which is basically thickening and scarring within that palmar fascia.
So it's like the body's healing response goes a bit haywire and makes too much scar tissue where it shouldn't.
Precisely. And this excessive collagen buildup is what forms those lumps you can feel, the palmar nodules.
Ah, okay.
And these thickened areas kind of organize themselves into those tough, stringy bands, the fascial cords that run from the palm out towards the fingers.
And those are what pull the fingers down.
Exactly. They contract, they pull the fingers into that bent position, and if it goes on long enough, the joints themselves can get stiff, sometimes irreversibly.
Right. Okay, so we've got what it is, the risks, the underlying process. Now, if someone comes in with, say, a bent finger and these lumps, what else could be going on? What are the differential diagnoses?
Yeah, that's crucial, isn't it, for getting the diagnosis right. You need to think about other hand problems that might look similar initially.
Like what?
Well, trigger finger is one, where a finger gets stuck in a bent position. That could seem similar at first glance. Different kinds of arthritis causing joint pain and stiffness, or maybe tendinitis, which is Inflammation of the tendons they could potentially be confused with, early Dupuytren's.
Okay.
Even simpler things, maybe like a callus, just thickened skin from rubbing, or perhaps a ganglion cyst, which is a fluid-filled lump. They might feel like a lump, but won't cause that progressive pulling down of the finger.
Are there any less common but maybe more serious things to keep in the back of your mind?
Yes, definitely. Although they're rare, you have to consider things like epithelioid sarcoma, that's a rare type of soft tissue cancer, or maybe a giant cell tumor of the tendon sheath. They can present as masses in the hand.
Okay.
And another one is ulnar nerve palsy. That affects a nerve in the arm and can lead to a sort of claw hand appearance, which could potentially be confused with late-stage Dupuytren'scontracture.
Good to have those possibilities noted. Now, just how common is Dupuytren's? What does the epidemiology look like?
Well, here in the UK, the estimate is around 5% prevalence in the adult population.
5%, so not insignificant.
Not at all. And as we said, it's much more common in older people, particularly men over 50. They're about 6 times more likely than women in that age group.
Right.
That strong family link shows up in the numbers, too. Somewhere between 60 and 70% of people with Dupuytren's report having a family history.
Wow, that high.
Yeah. And geographically, it's definitely most common in people of Northern European descent. That's why you sometimes hear it called the Viking disease.
Viking disease? That definitely helps it stick. Okay, so clinically, when someone walks into the clinic, what are the absolute key signs and symptoms that scream Dupuytren's? What does the picture look like?
The absolute classic signs are those nodules, the firm lumps you can actually feel under the skin in the palm, and then those thick cords that you can sometimes trace heading out towards the fingers.
Okay.
It has a real preference for the ring finger, the 4th one, and the little finger, the 5th.
Ring and little.
Exactly.
Mm.
You might also see the skin over these areas looking a bit puckered or dimpled. Often, the nodules tend to pop up first near the distal palmar crease. That's the crease closest to the base of your fingers.
And how does it tend to progress? What happens over time?
Well, as those cords tighten up, they start pulling the fingers down, causing those flexion contractures. And this can gradually start interfering with everyday activities. Shaking hands, gripping things, even simple stuff like putting your hand in a pocket can become difficult.
Right, impacting daily life.
Definitely. And it's worth knowing there are more aggressive forms. They can start earlier in life and progress much faster.
Oh, really?
Yeah. And sometimes you see involvement in other areas too, like on the knuckles, they call those knuckle pads or Garrett's pads. And seeing those can suggest a more aggressive disease course. You can also get similar tissue changes on the soles of the feet, or much less commonly in the penis.
So it can pop up elsewhere. Okay, during a physical exam, what specifically would a doctor be looking for?
We'd be having a really good look and feel of the hands, checking for those skin changes, the dimpling, the thickening, feeling for the nodules and cords, noting where they are and how extensive they are, and crucially, measuring the degree of contracture in each affected finger.
Measuring the angle.
Yes, specifically at the MCP joint, the big knuckle at the base of the finger, and the PIP joint, which is the middle joint.
Okay.
And we also use a really simple but effective test called the tabletop test, or sometimes Houston's test.
The tabletop test.
Yeah, you just ask the patient to try and place their hand completely flat, palm down, on a tabletop. If they can't get the palm and affected fingers flat against the surface, that indicates a significant contracture. It's a good functional measure.
That makes sense. Very practical.
And very rarely you might see other related finger deformities like swan neck or boutonniere, so you'd keep an eye out for those too.
So with all these clinical findings, are extra tests or investigations usually needed to confirm it?
Honestly, in the vast majority of cases, Dupuytren's is what we call a clinical diagnosis, meaning it's diagnosed based purely on that careful physical examination and listening to the patient's history. We don't typically need things like x-rays. They usually don't show anything specific to Dupuytren's itself. You won't see tendon calcification or anything like that.
Okay, so mostly based on the exam. Are there times you would do other tests?
Well, yes, perhaps. If the patient's history brings up significant alcohol use, given it's a known risk factor, we might ask more about that and maybe consider checking liver function tests. Similarly, if there are other clues suggesting maybe undiagnosed diabetes, another risk factor, we might think about screening for that, perhaps with a fasting glucose or an HbA1c test.
Makes sense, checking for those associated conditions.
Sure.
Okay, so once you've diagnosed Dupuytren's, what can actually be done? What are the management options?
Right. Management really hinges on how severe the contracture is and, importantly, how much it's affecting the person's ability to function use their hand.
Okay.
For milder cases, or maybe early on, non-surgical options might be tried. Things like hand therapy, maybe splinting, although there's actually a bit of debate about splinting and aggressive stretching. Some sources suggest avoiding it.
Oh, interesting nuance there.
Yeah. Injections are another option. You can inject corticosteroids or an enzyme called collagenase directly into the cords. The idea is to try and break down the cord tissue and allow the finger to straighten more.
Does that work?
It can help, yes, particularly for certain types of contractures. Another non-surgical approach, mainly for early disease, is radiotherapy.
Radiation for the hand.
Yes, low-dose radiotherapy. The aim is to try and halt or slow down the progression of the disease in its early stages. There are some long-term theoretical safety concerns, like a potential risk of skin cancer or sarcoma down the line. But importantly, no actual documented cases linked to this treatment have been reported so far.
Okay. And when does surgery come into play?
Surgery is generally kept for the more advanced cases, usually when the contracture is making it hard to use the hand for daily tasks or if non-surgical treatments haven't worked well enough.
Right.
The main procedures are things like fasciotomy. That's where the surgeon just cuts the tight cord to release the tension, or a fasciectomy, which is more involved, where they actually remove the affected fascia, the thickened tissue.
Okay. Cutting versus removing.
Exactly. We often think about severity in terms of impact. Mild, no real change in activities. Moderate, having to modify some activities. Or severe, significant impact. Surgery is usually considered for those moderate to severe cases. Very, very rarely, in extremely severe or complex situations, finger amputation might be discussed, but that's really a last resort.
Understood. So a range of treatments depending on severity. Looking ahead, what's the typical long-term outlook? What's the prognosis for someone with Dupuytren's?
It's quite variable, actually. For a small number, maybe around 10%, the condition might just sort of stabilize or even get slightly better on its own.
Oh, regression is possible?
It seems so, in a minority. But for the majority, maybe around 75%, it does tend to progress over time, leading to more significant contractures.
Okay.
And recurrence after treatment is, well, it's a known challenge. It's quite common, especially if the disease was quite advised to begin with.
Mm-hmm.
We also know it tends to progress faster in men and in people who develop it younger, say, before age 50.
Any signs that predict a tougher course?
Yes, there are features considered signs of more aggressive disease. Things like starting at a young age, having it in both hands if it affects the thumb or index finger, which is less common, or having those extra signs like knuckle pads or foot involvement.
Right. Those suggest it might be more troublesome. And what about after treatment, like surgery? Does that stop it coming back?
Well, surgery can definitely provide significant improvement in hand function by releasing that contracture. But it's really important people understand it's not always a permanent cure. Recurrence can still happen.
Okay.
And the risk of it coming back can vary a bit depending on exactly which surgical technique was used. For instance, a less invasive procedure like a needle fasciotomy might have a higher chance of recurrence over, say, 3 to 5 years compared to a more extensive removal of tissue like a limited fasciectomy or something called a dermofasciectomy.
It depends on severity, too.
So it's something that might need managing long-term, potentially. Lastly, what about complications, either from the Dupuytren's itself or from the treatments?
Well, complications directly from the disease itself, apart from the obvious impaired hand function and difficulty with activities, are pretty rare. The main issue, as we said, is that tendency for recurrence after treatment.
Complications from surgery, while not frequent, can happen. Things like potential injury to nerves or blood vessels in the hand during the procedure, maybe tendon rupture, infection at the site, persistent stiffness afterwards, or ongoing pain.
Standard surgical risks, essentially.
Pretty much. And as mentioned with radiotherapy, while considered theoretical, there's that long-term watchfulness regarding any potential risk, however small, of secondary cancers like skin cancer or sarcoma in the treated field years later.
Right.
But overall, the main impact is that Dupuytren's can be quite disabling, really affecting work, hobbies, and just day-to-day living for some people.
Definitely sounds like it can have a real impact. Okay, before we finish up, for everyone listening and trying to lock this in for revision, any quick memory aids or mnemonics?
Yeah, absolutely. For those key risk factors, maybe try remembering something like aging northern men smoking drinks sweetly. The sweetly hinting at diabetes, it captures quite a few of the big ones.
Okay, aging northern men smoking drinks sweetly. I like it.
And for the fingers usually involved, you could think ring and little like to twirl. Twirl. suggesting the contracture.
Nice. Ring and little like to twirl.
And the tabletop test just pictures someone trying and failing to flatten their palm on a table.
Yeah.
That image itself is the test.
Perfect.
And maybe a quick recall question to frame it. You see a 65-year-old man, Northern European background, complaining of progressive tightening and lumps in his palm, mainly affecting his ring and little fingers. What's the most likely diagnosis?
And the answer, based on everything we've discussed, is clearly Dupuytren'scontracture.
Exactly.
Fantastic. So just to quickly recap, Dupuytren'scontracture, it's that progressive hand condition, thickening palmar tissue, causing nodules, cords, and finger bending. Key risks: age, male, Northern European roots, family history, and definitely smoking. Diagnosis is mainly clinical. No cure, but various treatments to help function.
You've got it. And it really highlights that interplay, doesn't it? Between our genetics and our environment, our lifestyle choices, influencing how these things develop and progress.
It really does. A great point to consider. Okay, excellent. If you want to cement your knowledge on Dupuytren's and other key revision topics, definitely head over to passthemsra.com.
And also check out freemsra.com for loads of free resources.
Thanks so much for joining us for this deep dive into Dupuytren's contracture.